Okay, now we're going to do chapter 30. This is vascular. So we're going to talk about the peripheral vascular system. And when we're thinking about the peripheral vascular system, you have the arteries. Don't confuse this. Students always do. Your arteries, that's everything coming out of the left side of the heart. It's very well oxygenated. It carries oxygen. Then the veins they're after the capillaries. You remember you've got your arteries going down into the arterioles, your little tiny arteries. Then they go there into the capillaries, and then they carry the unoxygenated, no, stop, just get down. They carry the unoxygenated blood back to the right side of the heart in the venous system. So you've got your arterial side and your venous side. You can have vascular complications on either side, and we'll talk a little bit about like what those look like. And then you have the lymphatic system. The lymph is the liquid part of the vascular system. It's responsible for a lot of the immunological system, carrying the white blood cells around, initiating the immune response. We're not going to talk a ton about that. You can get lymphadenopathies and things like that, but we're going to talk more about that when we, like in the different disease processes. We've already talked a little bit about the lymph nodes. Okay, so let's talk about the arterial system. When we're talking about a problem on the arterial side, it's called peripheral arterial disease. When you're talking about it on the venous side, it's called PVOD, peripheral vascular occlusive disease. PVOD and PAD. Those are the two main things that we're going to focus on. So on the arterial side, when somebody starts developing peripheral arterial disease, much of the time it's because of high cholesterol and high triglycerides. Because of kind of like when we were talking about with the hypertension can be caused by that too. So what happens on the arterial side, you don't get deposits of cholesterol on the venous side. This is just an arterial thing. You start getting these deposits of cholesterol and fat laying down on the inside of the arteries. It can come down over to here. This is what we talked about with hypertension. And this can then lead to ischemia. So when the arteries start getting buildup of plaque, and by plaque we mean cholesterol, but a buildup of that can start compressing those arteries. And by compress, I don't mean on the outside. I mean it's like a building up of plaque on the inside, which is creating. So this is the inside of your artery. You've got a buildup of plaque here. Now you have significantly less space for the oxygenated blood to go through. Here's the problem. This can start occurring down, like in the arterial, in the arteries of the legs. You should be familiar with, and hopefully you learn this in assessment or skills lab, your pedal pulses when you're checking a patient's pulses. When you check somebody's pulses, especially when you're checking both of their pedal pulses, what you're checking for is to make sure that the blood that is being ejected from the heart is getting all the way to the systemic areas. So you check for your radial arteries to make sure the blood is going down the arms, and you check for those your dorsal pedal pulses to make sure that the blood is getting all the way down into the systemic system. When somebody starts having peripheral arterial disease, they can experience something called claudication. Claudication occurs when a patient starts increasing their activity. So if somebody has PAD and they're going for a walk or a jog or going up a flight of stairs, all of a sudden that patient has demanded more oxygen from their large muscles. So the blood is trying, to get to the muscles to give those muscles more oxygen so that they can work and do what what the body's wanting it to do. The problem is if there's an occlusion in those arteries, it's harder for that blood to get to where it needs to be, but those cellular muscle cells still want that oxygen. They're getting a lack of oxygen, and it causes pain. Every time your cells don't have oxygen, that's ischemia, and it's almost always painful. It's very painful. That's why heart attacks hurt. And when people are walking, increased activity, can't get the oxygen down there, it causes pain, and we call that claudication. That's one symptom that your patient has arterial disease. Another thing that you can do is if you think that your patient has that, because they'll come in and they complain that their legs are hurting with movement, check their cholesterol if they have high cholesterol, check their blood pressure if they have high blood pressure. Those could be signs that your patient has peripheral or arterial disease. A big problem is when the cholesterol starts laying down in the carotid arteries up here. Sometimes you get pieces of it in the aortic iliac branch. It can start building up in there. If it is so significant, sometimes the patient has to have surgery called an endarterectomy, where the surgeon goes in right into the artery and has to pull out pieces of plaque and cholesterol. The other things that they can do is first they'll do something called a stress test, because your patients who have angina, we'll talk about that in a couple weeks, but basically angina is when somebody has cholesterol building up in their coronary arteries, and the same thing happens is they'll be out working, shoveling. It happens a lot when people are shoveling snow. They're demanding more workload on their heart. The heart muscles are contracting a lot more and requiring more oxygen to get there, but because of the occlusion, the oxygen can't get there, and it starts causing ischemia. Now, in angina, if you get the person to rest, it's temporary and it doesn't actually cause cardiac muscle damage. That's the difference between angina and an MI, myocardial infarction. So angina doesn't lead to cardiac cellular death. They're at risk for it, but typically if you can get them to rest and put them on nitroglycerin, a vasodilator, you can get enough oxygen down there, you can avoid the cell death in the heart. Unlike a heart attack, which is complete occlusion of those coronary arteries. So if your patient starts complaining of chest pain, oftentimes what they'll do is they will send the patient for what's called first they'll do a stress test, where your patient will go into usually an outpatient facility, and they get on a treadmill, and they're all hooked up to EKG leads, and then they stress the patient, meaning they make them walk, they make their heart rate start increasing, and then they'll find out, is that leading to discomfort and pain, and find out what's going on in the heart. That's called a stress test, and that's just a diagnosis to see how well the heart can accommodate an increased demand for oxygen and an increased demand for cardiac output. Once they, if they find out that the person has failed the stress test or hasn't done very well, so if your patient is up on that treadmill and they're starting to walk and they're starting to have chest pain, they'll stop the test immediately. And then typically what they'll do is they'll send the patient to the cardiac cath lab. In the cath lab, sometimes they go in through the radial artery that you can feel right here. Sometimes they go in through the aortic artery, which comes off of the aortic iliac crest, so this is your aorta coming down here, and then it crests out down both legs like that. And they'll go in with a really long catheter like this. They go up into the arteries, and then they can look in these coronary arteries, and that's how they can find out how much an artery is blocked. So after a person goes for a cardiac catheter test, the cardiologist can determine if there's like a 90% blockage, a 50% blockage, or something like that, and then they can determine risk versus benefit of some kind of measure to improve this problem. The choices are either a stent, they can go in, if it's not 100% occluded, if it's just a little bit occluded, they can the cardiologist can do this right in the cath lab. They can load a little spring on the end of the catheter. They go up into these coronary arteries, and then they unload this spring. And what the spring does then is it's pressurized, and it shoves all this stuff back. Because this is all kind of squishy fat stuff, you know, like the fat you see on a steak or whatever. It's, you know, it's malleable. It's not hard. And it shoves this stuff back, and it opens it up like that, so it allows more blood flow to go through. And a lot of people get a stent. It's a lot easier to have a stent than to actually have a coronary artery bypass procedure. So, and I think there's a picture of a stent. I'll look. I'm not going to look for it right now, but I'm pretty sure there's a picture of a stent in your chapter. And then the stent just stays there. It's permanent, stays in there permanently. And then the artery just kind of grows around it. So that's one way to fix peripheral arterial disease in the heart. If the arterial disease is too significant, or there's too many vessels blocked, then the patient has to go for, I'm sure you've heard of it, a CABG, a coronary artery bypass graft. And this is a big surgery. They cut right through the sternum. If you get a chance to go see it, you should. I mean, they actually get the saw out in the operating room, and just, you can go right through the bone. That's why the patient is so sore afterwards. And then they crack open the chest. They have this machine that kind of like opens up the rib cage like this, and then the surgeon goes in. They have to bypass the heart. There's a machine that then they hook up the arteries to a bypass machine, and then reconnect it, so the patient is still getting oxygenated while the surgeon works on the heart. And what they'll do then is they typically take vessels from the leg. They take the big saphenous veins from the leg. They cut out a section of it, and then they come up here, and then they will replace this clogged artery with a new open vessel, like that. And they sew the new vessels out and around the vessels that are occluded. That's why it's called a coronary artery bypass. They've just bypassed the stuff. Graft. The graft is coming from a vein that they took in the leg. That's a CABG. And it's a fairly common procedure, but it's a very big procedure. I'm sure you'll take care of patients who have had a CABG. And you can have, you know, a 1 vessel CABG, and you can have a 4 to 5 vessel CABG. The more vessels, the bigger and the longer the procedure. So anyways, that's a CABG. They can do carotid endarterectomies up in the coronary, or the carotid arteries that go up into the brain. That's a little bit risky because they can't do, there's no like bypass thing, like a bypass procedure. So they have to, oftentimes if somebody has coronary artery disease, carotid artery disease, they'll often have it on both sides, but the risk comes in doing the surgery, and they only do one side at a time, and they're hoping the other side stays open, because you need one of those to perfuse the brain. When they go in and do the carotid endarterectomies, there's a high risk for stroke, because they go in and actually take the clot out, or the cholesterol out of the artery. But while they're doing that, there's a high risk that it can become ischemic beyond that, and then the patient strokes. So those patients usually are also in the ICU after surgery. One thing that you can do to determine if your patient has, like to confirm it, is to do Doppler studies. And these are fairly common. You may have seen these in the hospital, where you can just take, it's like a little machine. You can do it right at the bedside. I think there's a picture of it in your book. And you just put this thing, it kind of looks like a pencil, over the whatever vessel it is that you want to look at, and it can determine blood flow that is going through that vessel. So that's called a Doppler study, and a lot of your patients will go to Doppler studies. So if your patient starts having some signs and symptoms of arterial disease, they'll, one of the first things they do is Doppler studies in the presence of the other whole big picture. Like if your patient is overweight, have high cholesterol, high triglycerides, smokers are at higher risk for peripheral arterial disease. So that's this half, and that's the signs and symptoms that you're going to see in your patient who has peripheral arterial disease. Peripheral vascular occlusive disease can also occur in patients, but the symptoms are a little bit different. In the venous system, on the venous side, this is going back to the right side of the heart, in the veins going up into the right atrium, there's little valves all the way up the veins that go like this. So when the blood is returning back up, it'll go through the little valve like this, but then it can't get back down. That's how it gets back up into the right atrium, because you don't have a lot of pressure on the venous side. If you'll remember from hemodynamics, the pressure on the venous side is known as your central venous pressure, and it's not a lot. It's only between like 2 and 8 millimeters of mercury compared to the pressure on the arterial side, which is 120 to 80 millimeters of mercury. That's your blood pressure. But on this side, you don't have a ton. That's why you can start IVs in there, and you can hang your IVs just by gravity, and the medicine and stuff will flow through here because the pressure is so low. So the pressure of a IV bag based on gravity, that's sufficient enough to get the blood into the venous system. Now, if you and when you work at a ICU, you'll see this. If you put anything in the arterial side, unless you have that IV bag on pressure, like on a pressure bag that's higher than this, if you put anything in there, that blood will shoot up into that line because the pressure is so high. Because this is coming off the left side of the heart. And this is a big, huge muscle that's pumping that blood. So now you get over here to the venous side, and you've got these little valves in there that are, if they're working well, supposed to keep this blood coming up back into the right side of the heart. There's a lot of reasons this system can start failing. One thing that keeps this process going is good musculature. So again, people that work out and run and have good muscles in their legs, that helps compress all the veins that are in there, and it helps keep those veins nice and tight. Some people, and part of this is genetic, can develop varicose veins. And what happens in varicose veins, it usually happens a little bit later in life, can start showing up around 35 to 40, more common in 65 and older. But what happens is, as the structures that support the veins start getting weak and failing a little bit, then these vessels don't have the support around them, and so they kind of get sort of wobbly. Well, when they get wobbly, then these little valves are way out here. And so now the blood that's supposed to go up here just kind of rushes back, and then what happens is you can start getting pooling. People that have problems on the vascular side, they're prone to edema, especially if they've been on their feet for a long time, because the blood has a lot harder time getting up to the right side of the heart. So the blood kind of starts pooling down here. Patients will complain of like tired, heavy legs. People that have a lot of varicose veins, and the varicose veins, they start getting very tortuous like this. You can see them. They start, they're visible right underneath the skin. Those vessels that are like that have, they start getting engorged. They can be painful, but painful usually with just standing, if you're standing on your legs a lot. They can also lead to leg ulcers. Peripheral arterial disease can too, because when you have like arterial disease down in here, the oxygen can't get down. Those can cause ischemic ulcers. But on the vascular side, I mean the venous side, they can also start causing venous ulcers down here because of insufficient vessel strength. And so there's a couple pictures in your book of patients who get venous ulcers. So some of the things that you can do in your patients who have vascular disease, one, keep them off their feet. And when they are sitting down, you want to make sure they don't have pinch points. Like you don't want, a person who's sitting is in this position. This is our guy who's sitting. So if you've got on the venous side, if they've got PVOD, this blood has to get up here, and then it's got to get through this arch, and then it's got to get through this arch in order to get back to the heart over here. So that's hard on vessels that aren't working very well. So if you can have your patient laying, you know, typically if they're going to sit on the couch, even if they could sit like this, now they just have one angle, and this angle isn't bad if you can lay them like in a semi-Fowler's position. And that helps the veins and the blood that are in the veins use gravity to get back here, and then hopefully there's enough to get it back up to the heart. And you'll recall, as from down here, these vessels are smaller, and as you move up through the body, that vein is getting bigger and bigger and bigger, so it can accommodate more into the right atrium. So you're going to want to avoid prolonged standing. You're going to want to avoid long flights, because you can tell this is the problem, where it's hard getting something back up this vein, and if that leg is just sitting there and pooling, it can start developing clots. Like that. And then if you have a clot on the venous side and that clot breaks off, it's going to go right up here into the right atrium, right ventricle, and you're going to throw a PE. It's going to go right into the pulmonary system. So the clots that come from patients who have PVOD, they're at high risk for PE. The other thing that you can do in your patient that has PVOD is compression stockings or TED hose. They're fairly common and actually really quite useful. What compression stockings do and TED hose do, which is why this is so important to keep these on your patient, the problem is they're very difficult to put on. So in that engineering class that I do with the College of Engineering, I'm going to have them look at a way to figure out how to get those TED hose on easier, because people don't wear them because they're so hard to put on. So if you've ever put one on your patient, you know what I'm talking about. And it's just like the sock that you put on your leg, but it's really hard to get on because you want it nice and tight and snug. You want it to compress those veins, because the whole point is you're trying to get that vein nice and snugly in order to give it enough strength to get that blood back up there. It's like putting an ACE wrap around a swollen joint. It just gives it some extra support. So the TED hose are very important to wear, and you are going to have to do a little bit of teaching about how to get the patient to get them on, because what you don't want to do is you don't want to put the TED hose on and then find out that there's like a big fold in it right there, because that's going to put more pressure right at one spot, which is going to increase the risk of developing a clot. And you don't want it like compressing really hard in one area, because that's going to also make your situation worse if you're trying to get all this blood back up the vein and then all of a sudden your TED hose is on wrong and you've got like a big occlusion up there. So you do need to be a little bit careful with TED hose that it's nice and smooth and there's no pressure points, in order to help facilitate that blood getting back into the right side of the heart. So that's kind of it. That is vascular problems in a nutshell. PVOD, PAD. It's two different diseases because of two different sides of the heart, two different ways to manage it. With this, if the veins get too bad, there's ways to repair varicose veins now. Sometimes if they're that bad, they'll just take them out altogether. You've got plenty of other vessels. And the arteries actually have an ability to develop what's called collateral circulation. And this happens sometimes if let's say there's, this happens kind of up here in the, let's say it's in the aortic iliac split. Let's say there's getting some occlusion here and it's wanting to force blood through there. The arteries will start growing out and around it to give another path for blood to get through. That's called collateral circulation. Your entire arterial system has the ability to do that. It takes a while, so it's certainly nothing that happens immediately, but if you have this over time, your body will develop collateral circulation to accommodate that. This problem, on the PAD, your patient may also be on blood thinners because you want to help that blood get through these areas that are getting occluded. I can't think of anything else. Let me just double check through your book if there's anything else I wanted to tell you guys. But that's kind of it in a nutshell. Let's see. Let's see if there's anything else I need to tell you. This wasn't a super huge chapter. Oh yeah, there's a picture of on page 826 of a Doppler study. More Doppler studies on page 825, and she's assessing peripheral arteries. You know what? Honestly, I think that's all I needed to tell you. You know, do read through the chapter, kind of skim through it, but it's really all you kind of needed to know. Oh, there's some collateral blood flow on figure 30.7 on page 829, if you want to know what that looks like. And you know what? I think the biggest thing for students is to just keep in mind if it's a vascular problem or an arterial problem. So sometimes you'll hear it lumped together. They'll just say vascular disease or peripheral vascular disease, and you won't know exactly what they're talking about until you can start figuring out symptoms, like if it hurts when they're walking or if they're getting swollen feet, or, you know, then you can figure it out. You know what? That's about it. There's some aneurysm stuff, but we talked about that last time. Those vessels can have aneurysms in that. We're going to talk a little bit more about aneurysms when we talk about neuro stuff. But you can have an aneurysm in any of the arteries. It's problematic when it's up in the brain and one of them ruptures, but any of these, after they've had pressure on them for too long, can start dissecting or developing an aneurysm, and that's a little bit of a risky situation to be in. That's it. The other thing I just want to go over one more time is the difference between an ischemic event. That's an event where the clot just sort of lodges in the artery, but the artery remains intact. So you can have an MI or an ischemic stroke because there's something in the artery, and that's ischemia, versus a hemorrhagic event where the pressure has gotten so much, or there's an aneurysm in the artery and it ruptures, causing bleeding. That is a hemorrhagic event. Those are two, I mean, they're both vascular, but two different scenarios. Just keep that in mind. The reason I'm pointing that out again is because patients or students always forget that. All right, well, I told you about having blood thinners. You know when blood thinners are important is if your patient has a clot, a piece of cholesterol, a blood clot. Like, the other thing that can happen is if it's coming out of the pulmonary system, or if you've got AFib, atrial fibrillation, you've got like a little blood clot or something like that, the blood clots can also circulate through the arteries and can also go up into the brain and also lodge in there. So you can have either a cholesterol, a piece of plaque, you can have a blood clot, some kind of a blockage that's causing an ischemic event. This is why it's important to determine what kind of stroke your patient is having, if it's ischemic or if it's hemorrhagic, because if it's an ischemic stroke caused by a blockage in the artery, and they determine that on CAT scan, they can tell on CAT scan if there's blood in the brain or if it's an ischemic event. If it's ischemic, then they can go in with a very special catheter up into the brain and administer a medication that breaks down this clot and opens up that artery and will minimize how bad that stroke is. It's called TPA. So that's another thing to keep in mind. We're going to talk about that more, but that's TPA is something they give patients who are having ischemic strokes. I think that's all I want you to know about this chapter. Cellulitis. Cellulitis is pretty common. I know I'm looking at page 858. That is just an infection of the like fat tissues. Your surgical patients can get it a lot. It's just an infection in the tissues, sometimes related to vascular problems. Okay, all right, that's it. There we go. Done with that chapter. Okay, call me if you have questions.